A very good afternoon to one and all present here. Myself, Dr. Ram Kumar, JR, second year pharmacology, Department of Pharmacology. So, the topic given to me for this ITS fifth session is mechanism of action of organophosphates and newer methods and drugs for the treatment of the same. So, I'll be talking on this outline. So, first I'll be talking about what are these cholinesterases. Then I'll be moving on to cholinesterase inhibitors. Then we'll see where we can fit this OPCs in this classification. Then we'll talk about their mechanism of action, and further we'll move on to the newer methods for the treatment of OPC poisoning. Then finally I'll summarize my session. So moving on to the topic proper. So cholinesterase. So these enzymes belong to the family called serine hydrolases. So their main role is to split the neurotransmitter acetylcholine into acetate and choline. See, we have two types of serine hydrolases. One is acetylcholine esterases and the butyrylcholine esterases. We'll see the difference between both of them in the next slide. So basically, as we can see the weight difference. The main difference, even though they both show 50% structural similarity, the main difference is their site of location. This butyrylcholine esterases, they are in the plasma and liver, whereas this acetylcholine esterase, it is present in RBC cell membranes and nerve terminals and synaptic cleft. So the other than one important point is the rate of metabolizing this acetylcholine, where as you can see, it is very high in case of acetylcholine esterases, whereas this it is very low. Per se, like we can say, butyrylcholine esterases, they do not metabolize naturally occurring acetylcholine. They metabolize only the drugs like cocaine, succinylcholine, like that. So that is the main point we have to infer from this differentiation. And one more thing here I would like to add is this acetylcholine enzyme, acetylcholine esterase enzyme. It is coded by a single gene that which is located in chromosome 7, long arm of chromosome 7. That is the point here I want to add. Then moving on to the next, we can see the structure of this acetylcholine esterase enzyme, which has two parts. One is two sides. One is anionic site and the esteritic site. Our in this slide itself, we can make out the metabolism of acetylcholine. So, as you can see, this acetylcholine binds to both the site, both the esteritic site and the anionic site. So this esteritic site, they take care of this ester bond. They hydrolyzes the bond. So it can split the acetylcholine into two parts, acetic acid and choline part. So that we can see in this slide. So this is the basic structure of acetylcholine esterase enzyme. So next we will see the cholinesterase inhibitors. What are the inhibitors we have? So it's just a classification based on reversible or irreversible, how they binds to the enzyme. So as we can see, in reversible we have carbamates, and also in irreversible also we have carbamates. This OPC, here we have to concentrate on the OPC compound mainly fixed in the irreversible cholinesterase inhibitors. So with that we'll move on to the next topic. So, as we all know, organophosphates, they are organic compounds containing sulfur containing phosphorus. Containing phosphorus in them, and their general formula is this, wherein you have a phosphate central group which binds with the oxygen atom, and they have two alkyl groups. Here you can see this X. It denotes the leaving group. For example, if this OPC reacts with some compound, what is the compound leaving from this group? That is the thing denoted by X. So based on this X, they are classified into 4 groups, as you can see. So A, B, C, D. This is taken from Goodman and Gilman textbook of pharmacology. So you can see that in group A, the leaving group is halogen. In group B, it is alkyl thio. Like that, it is classified into 4 groups, and you can see the examples also. So in group A, we have taboon, serine, and all the nerve gases will be there. One more nerve gas, VX, will be in group B, but it is a nerve gas, but it comes under group B. So all that classification is just just to show that structure activity relationship of this compound. So based on this structure, they behave separately. So in this slide, we can see the mechanism action of OPCs. So already I told acetylcholine binds to both the anionic and esteric side, where this OPC binds only to the esteric side, which you can see in this image. So once this esteric site is occupied, either two things can happen. One thing, the enzyme can be inhibited irreversibly, or the enzyme can go spontaneous reactivation. The two things can happen. So once if the enzyme is get irreversibly inhibited, that process we call it as aging, that you can see in this image. So aging means once the compound gets bonded, covalently bonded to the esteric side, it starts losing its alkyl group one by one. So just by losing the alkyl group, the phosphate bond with the esteric site, it's strengthened, progressively it is strengthened. So that by that the enzyme substrate complex will become more resistant, or what do you say, more stable to the hydrolysis. It will not be hydrolyzed easily. That is the thing, we call it as aging. So once this aging happens, the enzyme then solely the complex they should wait for the new acetylcholine esterase enzymes to come and destroy the acetylcholine that is left in the synaptic cleft. So this is the point we have to take it from here, that is aging concept. So moving on, so this is what I earlier told, either it can go for spontaneous reactivation, or it can go for aging and it gets irreversibly inhibited. So that sums up the mechanism action of OPCs. Then we will talk about the newer methods and drugs for the treatment of OPCs. So the current scenario, so till date the FDA approved treatment for OPC is that we have atropine, AIIMS and benzodiazepines. These three are the mainstay of the treatment for the OPC poisoning. But still we have some issues like poor CNS penetration by the both atropine and AIIMS. And this AIIMS, they like what do you say, if we give AIIMS, it is not general to all the OPCs, it will go and reactivate the enzymes. So these AIIMS also agent specific. For example, it will react separately to separate nerve gases like tabun, sarin, like that. It responds to the different agents differently. That is the thing. Then limited stability. Once we give this AIIMS, it immediately get oxidized to its inactive form. That is the one issue we are facing with AIIMS. Then as we all know, if there is a delay in the treatment of OPC poisoning, we know the prognosis is also directly proportional to the delay. So poor prognosis in delay management, this is the current scenario. That is why we are expecting recent advances in OPC managing. So for this recent advances with the basic strategies is that we can see, like we have to reduce the time of atropine administration to the patient. So for that the few strategies are made that we will talk about later. Then so all the drugs what we are having are morely acting on the peripheral receptors. Their CNS penetration is low. So just to increase CNS penetration, some strategies are made that we will see, and to find novel agents rather than depending on atropine and AIIMS, we can go for novel agents which will be more specific and more efficacious than the available current treatments. So we will see one by one. So in atropine, to minimize the duration, to minimize the time lapse, they have made some strategies like nasal spray, nasal drops, dry powder inhaler, fast integrating sublingual tablets. As we can see, this is for example, the route of administration of atropine is IM, either IV or IM. So that a layman cannot do at the site of poison injection. So at those places we can have this kind of alternatives. So to where a layman can administer it administer this kind of formulations to the patient, so the time lapse will be reduced, so the prognosis might be increased. That is the advantages of this formulation. These formulations are under trial. Then moving on to AIIMS. So first in AIIMS, just to increase the CNS penetration, they have made some sugar oxime conjugates. So this sugar oxime conjugates have more CNS penetration. And one more concept is this Zwitter ion concept. So Zwitter ion, this this renders more CNS penetration to the oxime compounds. Then we can give intranasal obidoxime. So intranasal, it acts more faster, and more bioavailability will be more. And there are some phenoxyalkyl substituted pyridinium oximes also there. These are the these strategies are made to increase the penetration of CNS penetration of the oximes. Other than that, with the oximes, researchers are going on novel oximes like these compounds K203, RS194B. These oximes are also under trial. So that is the thing about oximes. So rather than depending on oxime reactivators, we can go for non-oxime reactivators. That is the current study going on. Like they found this anti-malarial drug amodiaquine and its analog ADOC. They both have this reactivating action. So reactivating action of paraxon, serine and DFP. So their acetylcholinesterase reactivating activity is more superior when compared to pralidoxime. So this can be a future like milestone in OPC management, non-oxime reactivators of acetylcholinesterase enzyme. So then moving on to the drugs under pipeline for this OPC management. All these drugs are used as adjunct. They are not like a substitute. These drugs were under trial for adjunct to the atropine therapy. For example, analogs of acetylcholine, magnesium sulfate along with atropine, N-acetylcysteine, human butyryl cholinesterase. This they are suggesting that it can be a bioscavenger of that acetylcholine OPC compound, like that they are suggesting. So, and ketamine along with the midazolam, it is being tried for CNS toxicity like status epilepticus and seizures. So these are the drugs under trial. Then this is a newer compound called ganaxolone. So it comes under neurosteroids. So previously we have some neurosteroids called allopregnanolone. The problem with allopregnanolone is less bioavailability, more CNS lipid, less bioavailability, shorter duration of action, and it has some metabolites like ketosteroids, which are more side effect, they act on more receptors and cause more steroidal side effects to the patient. So what they have done is they have taken that allopregnanolone and they made some substituted and prepared this drug called ganaxolone. It has more half-life, more bioavailability, and more and less steroidal side effects. That is the one point. Coming on to the mechanism action of this drug, we can compare this with midazolam. Midazolam acts on GABA A receptors. So one thing I want to add is GABA A receptors, as we all know, there are two compartments. One is synaptical GABA A receptors and the extrasynaptic. Our midazolam acts on this synaptical GABA A receptors, whereas this ganaxolone acts on both synaptic and extrasynaptic. So thereby it inhibits both phasic and tonic currents. So it is that's why it is considered more superior to midazolam in case of seizure status epilepticus management in a OPC poisoning patient. So to summarize my presentation, so since for the last 20 years, the basic management of OPC poisoning is based on atropine and oximes. So still it is a demand for a novel therapy. So our role is to find a new other some novel therapies and approaches for this OPC management. So with that, I will end my presentation. Thank you.